Our next speaker is Julie Johnson. She is the president-elect of this fine organization of ASCPT. She's the dean of the College of Pharmacy at the University of Florida and has been extremely active in pharmacogenetics her entire career. She's now leading an NHGRI-funded Ignite group on personalized medicine. So welcome, Julie.
So thank you for the invitation to present. And I want to talk a little bit about how we use pharmacogenomics to really have clinical impact. And so in my opinion, many of us in the audience have been working in the pharmacogenomics space with a variety of goals in mind. And as it relates to clinical translation, this is sort of the order that I think about things. So the PGRN for 15 plus years has been focused on pharmacogenomics discoveries, and there are many objectives with those pharmacogenomics discoveries. But clearly one of those is to be able to identify genetic variants that may be predictive and might be useful in the clinical setting in guiding drug therapy. And then 6 or 7 years ago, within the PGRN, the CPIC was founded, recognizing that we do have some examples that do meet that predictive level, and it might be helpful to provide guidance on when and how to use that information. And then the next step from that is taking, in particular, things recommended by the CPIC group, which I think you'll hear more about later, and actually translating those into practice. And I would say that in the pharmacogenomics space, there really have been two groups, if you will, really focused on that. First was a network-wide project in the last funding cycle of the PGRN called the TPP, or the Translational Pharmacogenomics Project, and then the newer Ignite network, which is part of the NHGRI. And so just a little bit about Ignite. It's a network focused on genomic medicine implementation, and the goal is to have demonstration projects that really focus on the barriers to actually implementing genomic medicine in the clinical setting, but also documenting the benefit and value of such an implementation. So there are 6 groups funded, but you will notice that 3 of the 6 are focused in pharmacogenomics. So our program at the University of Florida, the program at Vanderbilt University, which they call I3P, and then the third program at Indiana University, a program that they call Ingenious. And so clearly in the genomic medicine implementation space, there are, I think you can argue, better opportunities for implementation in pharmacogenomics than there are other genomic medicine examples. So I think the opportunities within pharmacogenomics in this space are fantastic. For more information, the Ignite website is ignitegenomics.org. And so at the University of Florida, we, as many others in PGRN at the time, began to realize that for this clinical implementation to happen, it was probably going to take some of our leadership. So those of us who had been focused on discovery work would need to take a clinical leadership role. And so we developed a vision with UF leadership on how to advance genomic medicine implementation. Our long-term goals include moving beyond pharmacogenomics, but we felt that that was really the best space. And so in 2011, our program was founded, and our first project was for CYP2C19 clopidogrel in post-percutaneous coronary intervention patients. I don't think probably many people in the audience need much education on the story with clopidogrel. Basically, it's a prodrug that has a 2-step bioactivation, and the active metabolite here is what exerts the pharmacological activity. And CYP2C19 plays a major role in the bioactivation of clopidogrel. As people probably also in the audience know, CYP2C19 has a common loss-of-function allele and a number of uncommon loss-of-function alleles. And these are very common in the population. The STAR2 allele, carrier status in about 30% of whites and blacks, and up to 70% of Asians. And there was really a building literature in the late 2000s around clopidogrel and CYP2C19. So very robust data showing, for example, that STAR2 carriers had reduced generation of active metabolite, which seems very obvious if you look at the metabolic pathway, and reduced antiplatelet activity as measured by ex vivo platelet reactivity function testing. And there was also a number of meta-analyses performed. This one published in JAMA by Jess Megan and colleagues focused on post-PCI patients as opposed to other sort of lower risk indications for clopidogrel. And the top graph shows the individuals who had one loss of function allele, so heterozygotes. The bottom is two loss of function alleles. And so for both of those, there was a significant increased risk, about 1.5 to 2-fold increased risk of major adverse cardiovascular events. And then the CPIC guidelines, the first guidelines were published in 2011 and updated in 2013, and they basically look like this. So patients who have acute coronary syndrome or have undergone a percutaneous coronary intervention and have CYP2C19 genotyping data available, there are basically 4 phenotypes that can be inferred from the genotype data. Ultrametabolizers that are based on a gain of function variant called STAR17. I'll actually come back to this in a bit and talk a little bit about some work we're doing with Voriconazole. Extensive metabolizers, or the sort of normal function, if you will. And the recommendation is that clopidogrel is fine for them with standard dosing. And then for those who carry a loss of function allele, either 1 or 2 copies of a loss of function allele, alternative antiplatelet therapy with either prasugrel or ticagrelor is recommended. And so it took us about a year to put all the pieces in place to launch our CYP2C19 clopidogrel program. And so we began that clinical genotyping in the coronary catheterization lab in June of 2012. And just to give you sort of a little bit of a feel, there's a lot of background work that has to happen. And so we had to build a number of things in the electronic health record. So we had to build the ability to order a pharmacogenetic test. And then we had to build the ability for that test to be seen. So we had to create a pharmacogenetic test or genetic testing spot. And so, for example, the physician ordering the test would find in their lab results section the genotype data that looked like this. And then, because we didn't figure the average physician would know what STAR2 for CYP2C19 means, we felt it was really important to build alerts that would help guide them. And so in consultation, in particular with the pharmacy group, where drug interaction alert fatigue is a major problem, people completely ignore alerts. And so we said we are not ever going to do an alert if there's not a clinical action recommended. And so if there's an order for clopidogrel in the record and they have an actionable genotype, meaning they have a loss of function allele, then they get a best practice advisory alert. And so this is what our alert looks like. And we put it in yellow to sort of grab their attention. We tell them what the problem is. And so it says the patient's CYP2C19 genotype is associated with very impaired metabolic activation of the prodrug clopidogrel, and have elevated risk for stent thrombosis and other cardiovascular events. We give them one sentence about the reason for that, and then the recommendations for alternative therapy. We also talk about the contraindications and cautions for those other 2 drugs so that they can think through that as well. If they want more information, they can click here. We have a phone number that they can call if they have more information. And the genotype is down here. We did not want that to be a prominent thing. We weren't really focused on them learning about the genotype. So it's there, but that's not really the center. And then they can actually change their order if they want to change to prasugrel, change to clopidogrel, or change to ticagrelor, or continue with clopidogrel. And if they checked the continue with clopidogrel, we asked them to explain the reason for that. And so we also knew, though, that because we weren't doing sort of point-of-care type of testing, rapid turnaround testing, that by the time the genotype data came back, most of the patients would be gone. So the typical post-PCI patient is discharged at about 24 hours. And so we had to have a mechanism to follow up because those BPAs wouldn't necessarily trigger because they were already gone. So the genotype would come back and they would already be gone. And so what we did is we got our clinical pharmacists engaged in the program, and they got in-basket alerts for every genetic test ordered. And so, for example, here it would say impaired metabolism and an active order for clopidogrel. And so that would trigger them then to go in, review the patient case, look at insurance because clopidogrel is generic, the other two are branded. There are huge cost differences in the two. And so going in and understanding, what battles there might be in terms of costs were important. And then they would reach out to the cardiologist to discuss the alternative and facilitate conversion to the alternative agent, and then work typically with the nurse in the physician's group to reach out to the patient and get the drug therapy changed. So that's all great. We had a very successful clinical implementation. We published our first year data a couple years ago in terms of uptake, number of tests ordered, percent of patients who had a test ordered. But then our next question really was, does that matter clinically? So we can do this, we can implement, but does it matter? And so Laurie Cavallari in our group was leading the effort to really evaluate the impact of the pharmacogenomic implementation on clinical outcomes. And so for this analysis, we took all patients who had a PCI and a CYP2C19 genotype in the first 2 years of our program, so June 2012 to June 2014, and they also had to be prescribed dual antiplatelet therapy, so aspirin plus clopidogrel after the PCI. In terms of data collection, this was all data that was contained in the electronic health record. And so we really pulled all the information we could about a variety of things about the patients at baseline when they had the PCI and the genotype, relevant clinical information in terms of concomitant disease, et cetera, their drug therapy. And then we looked for hospitalizations or cardiovascular hospitalizations or death in the 6 months post-PCI. And our primary endpoint was MACE, which is sort of a typical composite endpoint in cardiovascular disease trials. So cardiovascular death, myocardial infarction, stroke, or stent thrombosis were the things that made up MACE. And in our analysis, we looked at those who had a MACE event and first compared the loss of function allele carriers who had their drugs switched to an alternative agent versus continued on clopidogrel. The second analysis focused on loss of function allele carriers who got the alternative drug versus those who didn't have a loss of function allele and continued on clopidogrel. So we did a Kaplan-Meier analysis, but also because this was not a randomized prospective design, we recognized that there may be some differences in the study population that would lead to them not being switched. And so we also did Cox regression analysis, doing propensity score adjustment to try to adjust for any differences in those who got switched and those who didn't get switched. And so these are the baseline characteristics. These are the loss of function allele characteristics. There are no differences between loss of function allele carriers and non-loss of function allele carriers, which you really wouldn't expect. And so there were no statistical differences in any of these characteristics. And these are the typical things that you would look at for predicting an adverse cardiovascular event. There were some, though, that were numerically higher, and I'm just going to draw your attention to these last two. So AFib, patients were more likely to stay on clopidogrel, although not statistically significant, and then history of a GI bleed. And we really think that that's because the purported bleeding risk for the alternative agents is higher, and so there was a hesitation to move them to the alternative. And so it was things like that. So even though there weren't statistical differences, we felt there were some numerical differences that were important to control for. So these are the data in the frequency of the different genotype inferred phenotypes. And So we had 408 individuals included in this analysis. 31% of those were loss-of-function carriers, so IM and PM. Of the loss-of-function carriers, 54% had their drug switched to an alternative therapy, and in 84% of those who got switched, they were switched to prasugrel. These are the outcomes data. So in those individuals who had a loss-of-function allele shown here in the dotted line, loss-of-function allele continuing on clopidogrel, they had significantly higher event rate than those who had a loss-of-function allele and got switched to an alternative. Those who had loss-of-function alternative treatment did not have different outcomes as compared to those who did not have a loss-of-function allele but continued on clopidogrel. So really data, we feel, documenting the clinical benefit of a genotype-guided approach, and that those who the genotype would suggest they should not be on clopidogrel but continued on clopidogrel had significantly worse outcomes. And so to extend this work within the IGNITE network, we have a pharmacogenetics interest group, and so we have a project ongoing now, and there are 9 institutions, including UF, working collaboratively to collate all of our data. So these are all institutions that have implemented clinically CYP2C19 testing in the PCI setting, and so the goal is to see whether in this larger cohort we can validate the findings from UF. And so we're in a sort of a very aggressive phase of this project right now. We're anticipating we will have up to 4,700 patients in this analysis, and our goal is to have all the data in by April 15th, to have the data analysis complete by the summer and submit an abstract in the summer, and present and publish the data in the fall of this year. So fingers crossed that the data will show us the same sort of thing that we're seeing at the University of Florida. One of the pushbacks that we get in the cardiovascular community is that we don't have a randomized controlled trial. But we believe that, if these data are confirmed in this larger cohort, it may become very hard to argue withholding the use of genotype to guide clopidogrel therapy. I want to transition now and talk about another CYP2C19 substrate. So voriconazole is a drug that's the drug of choice or treatment of choice for invasive fungal infections and is extensively metabolized by CYP2C19. So the parent drug is the active drug in this case. And in the set of invasive fungal infections, trough concentrations less than 2 micrograms per mil have been associated with significantly worse clinical outcomes. And again, the clinical outcomes here are bad for these patients, a high mortality rate for these individuals. And so our hypothesis was that the ultrametabolizers, so those who carried a star 17 allele without a loss of function allele, so star 117 or star 17, would have greater risk for subtherapeutic trough concentrations. And there are some data in the pediatric population, I believe primarily from St. Jude, but really, really limited data in adults. And so Essam Hamadeh, a postdoc in my lab, will be presenting these data later this afternoon in the late-breaking poster session. But what we did is we prospectively enrolled 70 patients who were being treated with sort of full-course voriconazole, either for documented or suspected invasive fungal infection. And we monitored trough concentrations, which are part of the routine clinical monitoring for voriconazole. Those were typically measured at 4 to 5 days into therapy, and then we had genetic sample collection. And I don't want to steal all of Essam's thunder, but I'll steal a little bit of his thunder. And so we did indeed show that mean voriconazole trough levels were different by CYP2C19 genotype. So if we have the homozygous star 17, they had the lowest. They had the lowest trough concentrations. Those who had one star 17 allele intermediate, and then we grouped all of the other genotype phenotype groups together, and you can see their trough concentrations were on average 4 micrograms per mil. And then when we looked at the prevalence of a subtherapeutic trough, again defined as a level less than 2 mics per mil, in the ultrametabolizers, so those carrying a CYP2C19 star 17 allele, over 50% of them had a subtherapeutic trough compared to only 16% of all others. And so again, what happens typically is that somewhere between 5 and 7 days, TDM is done, the trough concentration is low, and then the physician has to figure out a dose adjustment. And so the reality is then that 50% of this cohort is sort of essentially unprotected or underprotected in terms of treatment of the infection during that first week or so of therapy. And so at this point, and Assam has much more data in his poster, at this point we're really evaluating the clinical implementation with a recommendation of a 25% higher dose. So this drug has some nonlinear pharmacokinetic properties. But we're also working with Stefan Schmidt at University of Florida to develop a sort of more elegant PK pharmacogenomic dosing model in which we would incorporate pharmacokinetic data as well as the genetic data to come up with a more refined dosing algorithm. And then finally, just a quick story, another implementation that we have done is with CYP2D6 and opiate treatment. And so we're really focusing on 4 drugs there, codeine and tramadol, where there are clear data. And then we have sort of softer guidelines around oxycodone and hydrocodone. And so we have done this in the format of a sort of a soft clinic-level study where we have some clinics where we're doing CYP2D6 genotyping, providing that back to the clinician and then letting them use that to evaluate whether they want to make therapy changes, and we're providing consults for those. We're doing an iPad-based iterative pain rating scale at baseline and then at the 3-month mark. So some clinics, they get the genotype data right away. In other clinics, they'll get the genotype data at the 3-month after the data are in. So we're about halfway finished with this study. Our target is 500 patients. And again, Laurie Cavalieri is leading this project. But I did just want to tell you one story. And again, this is sort of anecdotal. But this is one of the very first patients that enrolled in our study. He was at a treatment or at one of the clinics where we were providing the data initially. And so this is a guy who is 51 years old, has had chronic back pain following an injury for 5 years, had been on a lot of therapies, and was just not very functional, was in constant pain. And he's pictured here with his grandchildren because he had been unable to sort of take them to the park and play with them. So he was one of our study patients. Based on the genotype data, we altered his drug therapy, and for the first time in 5 years, he was drug-free, and he said, I can take my kids to the playground and push them on the swing. And so this is a quote from him. He said, taking this test changed my life. It's going to change a lot of people's lives. And so, again, this study may not turn out, and we may not really see this, but I think he was one of the first 10 patients we enrolled in this study. And so, again, sort of gives you a really positive feeling about trying to actually translate these things into clinical practice and have an impact on people's lives. And so to wrap up, at UF, we've successfully implemented a number of pharmacogenetic testing paradigms, if you will, and we've done those in sort of different formats. For the clopidogrel one, we have data documenting the benefit in terms of hard clinical outcomes, death, stroke, MI. And I guess what I want to sort of encourage and have this audience continue to strive for is we have to continue to work hard to build the evidence. And building the evidence is at multiple levels. It includes the discovery work, trying to sort of validate those discoveries in a clinical environment. So the Voriconazole, I think, is an example of that. And then when you have data that's robust enough, really moving that into the clinical setting and then trying to document the benefit of that clinical implementation. And so with that, I want to acknowledge and thank all the people that are part of our UF Health Personalized Medicine program. the trainees that are involved, that were involved in the things that I told you about, and then our funding, which included initially the PGRN funding for the TPP project, and now funding through our CTSA award, as well as the U01 from Ignite. So thank you.
Thank you. We have time for a couple questions.
Thank you, Julie. Great presentation. On the clopidogrel example, I think you mentioned that you were collecting in your database why patients were not switched when they had a loss of function mutation. I was wondering if you could comment a little bit on, you mentioned about the bleeding risk in a few people, but I suspect there were many, many others that didn't have bleeding tendencies like that. I'm curious if you can share the kinds of reasons.
Yeah, so we didn't always, so they didn't always fill that out. So we don't have the answer to that question in every case. We know it was a combination of, where we do know, we know it was a combination of first, the bleeding risk. I think that was clearly for some of the patients. The cost of therapy was an issue, and so if you had a patient who didn't have a prescription drug benefit, the highest risk period is that first 30 days. And while there are insurance programs you can, not insurance, programs you can go through with a pharmaceutical company to get the drug, patient assistance programs, you can't necessarily do that in the time frame that's really going to help in that 30-day risk period. And then sometimes it was just inertia, right? So either the physician didn't sort of feel strongly enough about reacting to the genotype. We had much higher conversion rate. I know in our year one data, we had 100% conversion to alternative therapy in our PMs, and 65%, I think, in the IMs. And so, some of it was just, how compelled did they feel to change? So I think there are a variety of factors. Some were just inertia in terms of the physician not wanting to change, having trouble getting in contact with the patient. We're not sure if there was one where we actually wanted them to change, called it a new prescription, but they didn't get it filled, but that certainly could have happened as well.
I'm just curious if you can comment on the lack of clarity on the treatment guidelines, I guess, because I think my impression, this is where you work, so I'm just curious if you can comment on that.
Yeah, so the current guidelines from the, so the CPIC guidelines are pretty clear, but the current guidelines from the American Heart Association and American College of Cardiology are either neutral or negative about pharmacogenetic testing. So they certainly don't recommend genetic testing. And the argument there is there are no randomized controlled trial data. Now, the Mayo Clinic is leading a randomized controlled trial, and from what I understand, it'll still be a couple of years before that's completed. But, we're hopeful that if we see in the 4,700 patients what we see at UF, it may provide evidence that will cause people to have to sort of rethink that position.
Julie, I enjoyed the talk. The question relates to the clopidogrel slide where you showed significant event rates who are 2C19 carriers. So I'm assuming those are the patients that had difficulty switching over or financial issues. So obviously the health conditions, comorbidities, and possibly socioeconomic status would have significantly impacted that. So can you really use that data to say your test was the driver of the event?
Well, so these are individuals where we had the test. So you mean that they got switched? The test
the
was
ones
the driver?
that were carriers but maintained on clopidogrel.
Yeah. So again, there were a variety of reasons, and that's why. And you don't really see that here, and I don't have the statistics. But in the Cox regression analysis, where we did propensity score adjustment, the data are similar in terms of the p-values, and so we did not include socioeconomic status in the analysis. I don't know that we have good data on that necessarily. So I think the argument would be these people had bad outcomes, and if If we have a barrier in terms of the cost of the alternative, then we need to sort of figure that barrier out. Now, we're getting ready to launch an implementation in Jacksonville, and we're actually going to be using the Spartan test, where we'll have genotype data available immediately. And so before they get discharged, we'll sort of have them on the right drug, which isn't necessarily what we did here, because there was energy that was required, both pharmacist talking to the physician deciding what they wanted to do, that getting translated to the patient, a new prescription being ordered, right? So there are lots of ways that this was harder than it has to be, and we really are hopeful that basically with that immediate turnaround genotype available at the time of the PCI, that we would have a much lower percent where the drug therapy wasn't altered.
Right. So in the setting of PCIs, the obviously stent thrombosis rate is thought to be 1 to 3% per year at most. So this study would not have the power to demonstrate stent thrombosis rates?
Not stent thrombosis alone, although when we get to the 4,700, we may. But I will point out to you, almost all of these events, as you see, were in the first 30 days. So it is during that high-risk period when they have sort of, high platelet reactivity due to the PCI. And, so it does seem it's really important to get the drug switched quickly.
Right. Certainly our cardiologists certainly value stent thrombosis as the most sensitive marker of antiplatelet action. So if you have that data, I wonder if that would be more supportive of what you're trying to do.
Yeah, we have the data, and, we definitely had 1 or 2 in these people that had events in the no drug change that had stent thrombosis. Again, we're hopeful, and we're collecting all of those data in this collaborative effort. And, we think there's a pretty good chance that with 4,700 individuals, we may have enough to look at the individual outcomes and not just the composite outcome.
One quick question, then we have to go to break.
Hi. I was wondering, now that you have CYP2C19 genotypes, the data deposited in the EMR, are you planning to reach out to other specialties outside of cardiology in order to inform them? I'm thinking now that we have CPIC guidelines for a number of antidepressants, if you have started, or what is your experience?
Yeah, we actually are working on an implementation with our psychiatry groups because we now have 2D6 and 2C19. And so we're sort of working through that process of, sort of putting into place all of the elements for both what the recommendations would be, how we build that into the electronic health record. One of the things is, right now we're doing individual tests. So, figuring out how we sort of do if they already have 2C19, they need 2D6, if they have 2D6. And so there are silly things like that that actually make the actual implementation a little bit tricky. But we're working with our site group on an implementation for the antidepressants.
Okay, thank you.
Thank you.
Let's thanks Julie for a fantastic talk.